So welcome everyone to our fifth Lunch and Learn of 2025, the Ask the Expert Educational Dementia Series. I'm Wendy Farthing, the Director of Community Integration with MAC Incorporated, the Maryland Living Well Center of Excellence. I'm here today with Jane Marks, the Associate Director of Johns Hopkins Geriatric Workforce Enhancement Program. She's a nurse, Division of Geriatric Medicine and Gerontology. And we've partnered to offer this opportunity to engage in monthly topics of interest with various dementia experts. If this is your first time joining us, we welcome you and encourage you to visit our website for previous recordings, PowerPoints, and resources. And if you're returning to the series, we welcome you back and we're glad you chose to join us. Very quickly, I'm going to share a couple of resources that you have access to. Our virtual statewide offerings for caregiving, dementia, and diabetes workshops. We also have 88 screening opportunity. The 88 screener interview is a brief 8-item interview tool used to differentiate between normal aging and the early signs of dementia, including Alzheimer's disease. It's designed to be complete quickly and easily by an individual or a trusted informant like a family member or caregiver. And it assesses changes in memory, orientation, judgment, and functional abilities. There's also a link here for Maryland Access Point. MAP specialists work with caregivers, professionals, and all individuals with long-term care needs and plans to identify, connect, and assist folks accessing private and public resources for long-term services and supports. We have an Alzheimer's dementia conference down in Salisbury on June the 11th from 9 to 3:15. So you can click on that link for more information there. And most importantly, our contact information. So if you have questions, suggestions, you want to sign up for classes, you can reach us here. So we did get a number of questions during registration that we will be answering today. You're welcome to put questions in the chat and we'll attempt to answer those questions today. And what we don't get to, we will have resources on our website and have that posted with some answers. So I'm going to turn this over to Jane Marks for her to introduce our speaker today, and we'll get on with the program. So thank you.
Thank you, Wendy. Welcome, everybody. We're excited today to have Dr. Haroon Burhanullah from our Division of Neuropsychiatry. He is also an assistant professor at Johns Hopkins and also the director of the Alzheimer's Anti-Amyloid Therapy Clinic. So we're excited to have him and his expertise and sharing with us understanding the non-Alzheimer's dementia. As you remember, we've gone through some of the basics in our previous sessions about Alzheimer's disease. Last month, we had a presentation on Parkinson's disease, and I think some of the questions that came in on this session today, you can actually look at that video and find some of the content information that you're interested in. So I'll let Dr. Burhanullah start with the first slide, and welcome.
Thank you, Jane. Appreciate it. So Alzheimer's dementia is the largest type of dementia. It's basically, I'll just directly start with, since our time is limited, the 60 to 65% dementia types are an Alzheimer's type. The rest of all dementia, inclusive of like vascular, mixed dementia, dementia with Lewy body, and FTD, comprise of about 35% of dementia types. About 15 to 20% patients have vascular dementia. A lot of patients who have vascular dementia actually sometimes have coexisting Alzheimer's dementia. So they have mixed pathology. So there's another mixed pathology that happens with Alzheimer's is Lewy body dementia. Sometimes Lewy body dementia and Alzheimer's dementia coexist. So and in that case, that's why the number of mixed dementia is about 15%. And then the frontotemporal dementia and alcoholic dementia, those are like less than 5%. About 20 to 30% of patients with Parkinson's disease does develop dementia after 8 to 10 years. However, overall, but it comprises about 3 to 5% of dementia types. So, but it's important to understand that if someone has non-Alzheimer's dementia, they can have some sort of a mixed Alzheimer's pathology, especially if we are dealing with vascular and dementia with Lewy bodies.
Next slide, Wendy. So I think today, due to time, we're going to try to address these three non-Alzheimer's dementia cases that Dr. Burhan talked about. But we're going to start out with our first question, and that's the next slide, Wendy, is what is vascular dementia, and could you tell us some things about risk factors, how it presents in a person, what workup does usually take place, and how do we manage that?
Sure. So vascular dementia is a type of dementia, which is actually the second most common type of dementia. It's caused by a vascular condition, a pathology in the brain of blood vessels. It's due to the impaired blood flow to the brain, and the impaired blood flow to the brain could be from a variety of reasons. Number one could be like stroke, or it could have like the patients may have like high, plaque in the brain and small vessel disease or any ischemic injury. It does, as I mentioned, it does coexist with Alzheimer's dementia oftentimes, but in itself it can happen. There are some various risk factors, including like most common risk factor is hypertension, diabetes, smoking, history of stroke, and sometimes chronic kidney disease. Those are the risk factors. In these patients who have diagnosed with vascular dementia, they usually have a plateau stage and then they decline right away after there is any cognitive insult, any vascular injury in the brain. So there is a stepwise decline in cognitive function. Initially, memory loss may not be the first symptom. The first symptom usually in these patients have executive dysfunction, and cognitive processing speed slowing. They usually take longer to process the same, information. It takes longer for them to answer questions. So that's how these patients present. But then eventually memory loss does happen. These are the patients who do not have, like, majority of these patients have problems with memory eventually, but the initial symptom is executive dysfunction along with some short-term memory recall. So that's the main presenting symptom of vascular dementia.
Wendy, if you could go to the next couple slides, I think they're kind of highlight things that he talked about, the risk factors that he mentioned and clinical features.
Yeah.
And then I think the diagnosis.
Yeah, diagnosis. So diagnosis is based on, for vascular dementia, is based on the clinical history, neuroexam, and MRI of the brain. MRI of the brain does show infarcts or white matter changes, which which essentially shows that there are some dead blood vessels or small blood vessels in the brain, and then cognitive testing. However, in diagnosis, it's important to understand that there is a temporal relationship between the cognitive decline and any vascular event. For example, if someone has a stroke and then they start having problems with memory, like a month later or 2 months later, soon after the stroke, then we know that there is a relationship between the memory loss and also that vascular injury, which is stroke. Likewise, if someone has a heart attack or myocardial infarction, it can usually follow that. But oftentimes, the patient does not have a clear, like vascular injury that they can delineate. In those situations, it's mostly TIA or what we call a silent stroke. In those situations, that can also cause vascular dementia, and in that case, vascular injury may not be evident. Now, there is also interesting thing that patients who have this could be a very common theme of mixed dementia. Patients who does have like cerebral amyloid angiopathy. This is a term that is used for CAA, which is cerebral amyloid angiopathy. It's a condition where the patient's blood vessels are fragile and they tend to bleed. These patients are the ones who are most commonly, almost always, have mixed Alzheimer's and vascular dementia. So it's very important for a physician to diagnose that, usually with a good machine, 3 Tesla machine, we can pick up the cerebral amyloid angiopathy. However, with regular MRIs, if it's read well, we can actually diagnose someone with the CAA, which is essentially leads to the mixed pattern of dementia. We can move to the next slide. So yes, so there's no cure for dementia or vascular dementia. Usually the cure, it's all about lifestyle modification and blood pressure control, making sure that patient does not have any future further stroke. Usually high blood pressure, high cholesterol can make it worse. I usually recommend 3 types of stimulation: physical activity, increase physical activity. Second thing is cognitive activity. Cognitive stimulation could be like playing Sudoku, word puzzles, things like that. And the third thing is social. So socially, if the patients are active, those 3 things, if they continue to do, it's good for both Alzheimer's too, but for vascular dementia, that is the only thing that they could do that usually slows down the decline or prevents further progression of the disease and prevents essentially further vascular injury. And physical activity improves cognition. So it's very important to have these patients be physically active in whatever capacity they can. So it's important. Um, I mean, those are as I said, there's no cure, but if patient has a mixed dementia pattern, like Alzheimer's and vascular, or sometimes they have in those types of patients, medications like acetylcholinesterase inhibitor, which is a treatment for Alzheimer's disease, Aricept, donepezil, those medications can be helpful.
And it sounds like keeping them active even if after they go through maybe physical therapy from a stroke is really important.
It's very
Thank
important.
you.
Yeah. Mm-hmm.
Thank you. So moving forward, could you describe a little bit about dementia with Lewy bodies, like including what causes that, and are
Yeah.
there treatment modalities for that?
Right. So Lewy body dementia is caused by it's first of all, it's a neurodegenerative disease. It's caused by alpha-synuclein, and most patients with Lewy body dementia are usually, when I describe this type of dementia to patients, I usually say that this is a cross between Alzheimer's and Parkinson's dementia. When I say cross, because these patients have symptoms of, like, they have increased level of amyloid, and they have also alpha-synuclein, which is present in Alzheimer's disease, in Parkinson's disease. So these alpha or Lewy bodies are these are restricted to basal ganglia portion. In the Lewy body disease, it's overall in the brain, in the neurodegeneration, in the cortex, but in Parkinson's, it's in the basal ganglia. And moreover, they also have amyloid in the brain. The way to diagnose these patients are essentially brain MRI, cognitive test, and now we have biomarker evidence. Skin biopsy sometimes helps. Skin biopsy for alpha-synuclein, they can, or DAT scan, that can help. But if patient has, I mean, in our case now, there are so many advances in Alzheimer's and Lewy body disease that we can actually diagnose with the plasma biomarker, with also the amyloid testing as well. If someone has amyloid positive and also positive for the alpha-synuclein, so we can say for sure these patients have, like, dementia with Lewy body. But clinically, it's very clear the diagnosis. These patients usually differ from the Alzheimer's patients clinically too. You have a suspicion. The initial symptoms are almost similar, like similar to Alzheimer's. Like they have problems with word finding, they have problems with memory, but usually these patients have specifically these Lewy body dementia patients have Parkinson's symptom. For example, they will usually fall forward, and they will have visual hallucinations. Those are a hallmark of the disease. These vivid hallucinations and vivid dreams. They have like pretty dream enactment, and so much so that they get sometimes they thrash and sleep. So sleep disturbance, visual hallucinations, memory problems, and motor symptoms. So those are the common, hallmark of the Lewy body dementia patients.
Next slide. Oh, thank you.
Yeah, so the treatment, these patients with Lewy body, neurochemically, they are deficient in a chemical called acetylcholine. We know that patients with Alzheimer's disease are deficient in acetylcholine, but these patients are more deficient in acetylcholine. Hence, the medication donepezil is used to treat these patients to slow down the decline. It's not a cure; it's just a treatment. But majority of the cases of these types of Lewy body dementia patients, they present with vivid hallucinations and some paranoid delusions. So initially, we start with the non-pharmacological management of these uh, delusions, try to redirect them, improve the lighting. It's important to improve the lighting because as soon as it gets darker, these patients starts to have like those fluctuations. These fluctuations are very common in the earlier morning. It can happen anytime, most common in the early morning and during this sundowning phase, which we call at evening time. So it's important to kind of light up at nighttime, evening time, slowly, introduce, because when it gets dark immediately, and slowly like, dim the light, and that's how it works. And there are medication that can help with delusions or hallucinations, but we can talk about it when I talk about the neuropsychiatric symptoms further. So yes, so these patients clinically, uh, how you can differentiate from Lewy body with Parkinson's disease. That's most commonly confused. Lewy body dementia patients present with motor symptoms, and when you see the patients walking, and if you don't interview them, they appear exactly like Alzheimer's. They appear exactly like Parkinson's. They will have shuffling gait. They will have tremors, and like they will be pretty stiff. But if you take a good history, it appears that these patients have memory problems and the motor symptoms of Parkinson's disease within 2 years of each other. However, on the other hand, patients with Parkinson's disease, they are diagnosed with Parkinson's motor symptoms first. They're cognitively well, quite until they are quite advanced in the stage of Parkinson's disease until like 7, 8 years, and then they start having memory problem. Moreover, mostly patients with Lewy body, they have memory problems first rather than later initially. And then most common symptom in patients with dementia with Lewy body is short-term memory, and then the motor symptom starts. Memory symptoms starts first, motor symptoms starts later. It's the other way around in Parkinson's disease. And then, differentiating from Alzheimer's is pretty easy because Alzheimer's patient does not have those prominent Parkinsonism symptoms or motor symptoms. You can move to next slide.
Moving
Yeah,
to the next slide, we're going to talk. I would like to ask you a little bit about frontotemporal dementia. How does that present, and what is the cause and management? And then, giving us some highlights on that would be appreciated.
sure. So frontotemporal dementia, or we call it FTD, it's caused by atrophy of as the name sounds, it's a neurodegenerative disease, atrophy of the frontal lobe of the brain and the temporal lobe of the brain. However, there are two main presentations of frontotemporal dementia. It's important to understand that there are two different types of frontotemporal dementia. The most common that we all know and the people know are the behavioral variant, where there's personality changes, where the patients lose modesty, they get disinhibited, they have social inappropriate behavior. For example, they'll undress themselves in front of their granddaughter. So those types of behaviors. And then they have apathy, meaning they are not interested in doing things. So those are behavioral variant of frontotemporal dementia. That's how they present. Mostly these patients present in their 50s, and these patients have like a predilection for eating sweets. They have apathy, meaning they have no or pretty decreased desire to do anything or initiate any task, and they are disinhibited. I usually give an example of a patient who was standing at the stop sign, not stop sign, at the red light, and all of a sudden it occurred to him, and he crossed the red light. So they are impatient, they are disinhibited, they just make poor decision, and then sometimes they get into those types of accidents. So the other variant of frontotemporal dementia is primary progressive aphasia, which means that patient has problems with language. They can't speak. They are able to understand it, the language or whatever you are saying initially, but they can't express themselves. It's really like a tongue tie, and they are able to understand, and but yet they're not able to say something, which is very depressing for them because they are quite aware of what's going on. So, which is one of the most depressing things for them. And eventually, they lose ability to, since the temporal lobe is involved, they lose ability to understand the information. And as the disease progresses, they have problems with memory as well. But usually it starts in the first 2 to 3 years by word finding problem, not able to understand first, and then they also have trouble reading. So that it's important to note if someone has been having problems with expressing themselves and reading anything that they used to read in the past, then that's a concern. For both these cases, now FDA has Medicare and FDA both has approved this scan. We call it FDG, a glucose PET scan. Glucose PET scan can distinguish between Alzheimer's dementia and frontotemporal dementia. You can see hypometabolism clearly in the frontal and temporal lobe, meaning reduced sugar uptake. That part of the brain is less active. So glucose uptake is reduced in that area of the brain. So that's why we call it hypometabolism. On scan, uh, CSF testing has no significant benefit because there is no amyloid and there are tau is increased, but tau is very non-specific. Tau itself, if you just test tau, it's also increased in other types of dementias. So that's why FDG PET scan is very classic, and then MRI of the brain is done. But these patients, again, this dementia also does not have any cure. And the most important thing or hallmark thing to note for this type of dementia is its supportive care. A lot of patients have, family members have reported that the first thing that appears is that the behavioral variant of frontotemporal dementia, they get diagnosed rather earlier because they have problems with social disinhibition and they have significant personality changes. But the primary progressive aphasia, because patients try to just deal with it on their own until the spouse or other family members get aware that they are not able to speak, they seek medical help a little bit later compared to the behavioral variant. So that's about it. Yeah, I think I talked about it, frontal supportive care. By the way, we have Dr. R.G. Hillis at Johns Hopkins, who has expertise in frontotemporal dementia. She is doing, although there is no cure, but she is, in what have last heard, she was doing a trial on the direct, the stimulation of one of the nerves as a trial for frontotemporal dementia. And Dr. Chadi, for primary progressive is aphasia part of frontotemporal dementia. But Chadi Unike at our Johns Hopkins campus, he has expertise in the behavioral variant and other types of frontotemporal dementia. We can move forward.
Okay.
Oh, I'm sorry. Before we move on, how long has it been that we've recognized frontal temporal dementia compared to Alzheimer's disease? Is that in the last 20 years or so, you think?
Yeah, it's not a new diagnosis. It has been Alzheimer's has been diagnosed, like has been the longest diagnosed, but the primary progressive aphasia part of frontotemporal dementia, sometimes they get confused with Alzheimer's disease because that part that has been in the last 10-15 years, but the behavioral variant was obviously diagnosed a little bit earlier, long time ago.
Okay,
20,
thank
yeah.
you. Just so moving forward, if you could address briefly some things about the rapidly progressive dementia.
Sure. So the rapidly progressive dementia types, there are different types of dementia. Uh, First of all, when we talk about rapidly progressive dementia, we are talking about only a couple of months, or 2 to 3 months, weeks to months. And these are the patients who there is a rapid change in cognition. And these patients, initially present with, we have to distinguish with delirium, but these patients present with a change in mental status so quick that initially it's taken as delirium, like changing, waxing and waning of alertness, acute change in mental status. These are the prion disease. You can move to the next slide. Yeah, these are the prion disease, Creutzfeldt-Jakob disease. You probably have heard of this Creutzfeldt-Jakob disease. Uh, Most patients with Creutzfeldt-Jakob disease, they develop from cognitive impairment to dementia within 3 to 4 months. And this is a contagious disease where an infection from the leads to a protein, changes in the misfolding of the protein, prion protein, and these patients develop as a result these patients develop like severely cognitive impairment, appear confused, have like seizure disorder, and they eventually most of these patients, the mortality is also pretty high, and most patients tend to die in 6 to 8 months of these types of patients. We can diagnose this with the brain MRI. They show in a brain MRI, they show cortical ribboning. It's a very specific cortical ribboning pattern. I think I've also had a slide of the MRI, and they have CSF pattern of 14:33. So elevated protein, tau protein. So those are the two diagnostic modalities, CSF and MRI. No treatment. It's similar to mad cow disease, if you will. I think there is an MRI. I have.
Yes, next slide, Wendy. Yeah.
Yeah, exactly. Okay, so you can see this pattern, this is like a cortical ribboning on the sides. Usually, brain MRI is pretty smooth but you can see the gaps. This is like a specific, you can see the white shiny light. This appears as a cortical ribboning, classic for prion disease, and these patients, this is not a good sign. Other types of dementia, autoimmune encephalitis, or we call it limbic. And there's another type too, third type, which is limbic encephalitis. It can happen due to an infection. Usually, patients are pretty psychotic. They appear, the most common symptom is they have specific delusions and hallucinations. They tend to have visual hallucinations most commonly. That's how they present in the hospital, and they are very confused. They're usually disoriented, and after a while, you basically determine that after doing the LP, that these patients have a specific elevation in GAD65 on an anti-NMD antibodies, which is a paraneoplastic panel, which is an infectious panel that you diagnose. And then these patients can be treated with rituximab, plasmapheresis, steroids. These are the hallmark of the treatment. But alongside with this, we usually prescribe Depakote, which is a mood stabilizer, and any antipsychotic, because those patients, the first symptom or the most common symptom is confusion and psychosis. That's how they present in the hospital. And most of these are presented in our neurology unit, in an inpatient unit, and usually the psychiatric consult team, along with the neurologist, are able to diagnose those patients.
I think we have a little bit of time left. Perhaps we could just address sleep and dementia. That was one of the questions I think that came up in our survey beforehand.
Yeah. Okay. So this sleep and dementia is not specific to any specific type of dementia. First of all, I just wanted to clear. Sleep, usually patients who have a neurodegenerative type of dementia, especially neurodegenerative type of dementia, like frontotemporal, Parkinson's, Lewy body, and then Alzheimer's dementia, they have disrupted circadian rhythm because of the shrinkage or degeneration of the suprachiasmatic nucleus, which leads to a chemical called melatonin. So melatonin is decreased in these patients. They have a reversed or sleep-wake cycle, and they tend to wake up at nighttime and sleep during the day. Usually, as the disease progresses, as the dementia progresses, this sleep disturbance increases. We actually have done a study at Hopkins Memory Clinic on circadian rhythm, and found an association of circadian rhythm, problems with Alzheimer's disease. So it has been multiple studies have been done, but I think the melatonin supplements usually may help. And melatonin supplement suggestion is to take it 2 hours before they go to bed. before they go to bed. So that's the recommendation. But it certainly causes fragmented sleep and early awakening and daytime, sleepiness as well. So it's important that these patients have a structure during the day. If they are not doing anything, they sometimes having a structure in the day and then taking melatonin helps. If they have if they are busy during the day, going to the senior center, doing some cognitive stimulating activities, that usually helps at nighttime too for sleep. But if they don't do anything, then sometimes just boredom or just not doing anything, they tend to fall asleep, and that is a vicious cycle. That's why having a structure in the day is extremely important.
Next slide, Wendy, might be also helpful to talk about light therapy.
Yeah, bright light therapy, non-pharmacal, that's a treatment. But usually if it gets too far, then we treat with regular, avoid late night, late naps, calm night environment, and bright light therapy, especially in the morning when they wake up. Yeah, but melatonin usually is also required. To start with, we use melatonin. Later on, if it doesn't get better, bright light therapy or just sticking outside in the sun, that usually helps too.
I think we have a few more minutes if we want to talk a little bit about the NPI neuropsychiatric inventory.
So, just so that I can explain, majority of patients with dementia has neuropsychiatric symptoms. Unfortunately, these neuropsychiatric symptoms are hallmark of dementia. About 95% patients who develop dementia at some point during any stage of dementia, they will develop these neuropsychiatric symptoms. In early stages, it may be less pronounced, but still it's common. There was a term that we use. I don't want to go into very specific, research detail. We use we call it mild behavioral impairment, which is a term called MBI, mild behavioral impairment. This precedes the cognitive impairment in a lot of patients, and hence we know that patients who have mild cognitive impairment sometimes they are well aware of the diagnosis. It leads to anxiety, depression, and later on, just agitation and delusions become more common in about like mild to moderate stage of the disease. So, but these neuropsychiatric symptoms essentially comprise of, I usually call it three main components. One is mood and anxiety, which is the one affective component. The second is the psychotic component, which includes the delusions, hallucinations. So those are the psychotic component. The third component is the dysexecutive function component, which includes the disinhibition, irritable mood, agitation, apathy. Those are the three main complexes that's how I see it. But majority of patients starts with having the affective component, which is the depression and anxiety, which is very, very common along with any type of dementia. But then it becomes a problem when they start getting agitated and delusional and hallucinating. That becomes a problem. So, but it's important and it's treatable. The good news is it's treatable. We can actually start patients with the SSRIs, which is we did a trial on Citat, any antidepressant like escitalopram, sertraline, those types of medications usually help. It does take 9 weeks to work, 9 to 10 weeks, but it does help those patients. We can move to the next slide.
Yeah, I think this will have to be our last slide because of time, because we did have a couple questions, but this is one of the questions talking about depression in Alzheimer's disease, or could depression be mistaken for Alzheimer's disease, that I think we talked in the past about, but thank you.
So depression is not mistaken in Alzheimer's disease. Depression in Alzheimer's disease usually coexists, unfortunately, in patients with, and I'll tell you why. It is Alzheimer's disease is a neurodegenerative disease, meaning shrinkage of the brain. Usually the serotonin transporters are also, decreased because of the shrinkage of the brain. And these patients do get depressed, organically, these patients get depressed. And so patients with Alzheimer's, once they're depressed, and these depressive symptoms, anxiety symptoms, they can make memory worse. We have a paper that, patients who have these neuropsychiatric symptoms, those patients decline from mild cognitive stage to a dementia stage, and from the mild stage to even advanced stage if their depression is not treated. there is also one thing which is very important to understand, that in geriatric patients, depression presents, the cognitive impairment presents as the first symptom of severe depression. So patients who do not have Alzheimer's disease, they sometimes get very depressed and they appear cognitively impaired. However, when you treat that type of depression, we see that the cognition has improved significantly to the point and we know that those symptoms are only related to depression. So it's important to distinguish just cognitive impairment and depression from, like, what you used to call pseudo dementia, but depression usually does coexist with Alzheimer's disease. These days it's pretty easy. Now you do a biomarker testing whether or not patient has biomarker for Alzheimer's, and the patient is depressed. We can see, this is an Alzheimer's patient who's depressed. If the biomarker is negative, patient has cognitive impairment and depression, we know this is likely depression is making the cognition worse when the biomarker is negative. So it's pretty easy now these days. But yeah, but you need to see
So
a memory specialist.
oh, go ahead. I'm sorry.
But you need to see a memory specialist who knows what kind of biomarker to order. I mean, Johns Hopkins Memory and Alzheimer's Clinic, that's what we usually do, and we have expertise in that.
And that's a good opening to, I think, a question and comment that we've received prior to this, as well as on this slide in our chat room is, where do we go? Like, are our primary care docs equipped to diagnose some of these unusual dementias, or do they need to be referred to such as a memory center, which we know is, limited in available appointments, neurology? What are thoughts in that regard? Where do we go as a patient or family member concerned?
The primary care doctor, if they are able to do some cognitive tests, some of the primary care are pretty diligent and they do a cognitive test and they see that the patient has scored, below a certain cutoff, and they are alarmed. They usually send patients to the memory doctors. This to diagnose different types of dementia, specific type of dementia. What I have noticed seeing patients in the memory clinic, that they are able to say that patient has cognitive impairment, but usually distinguishing between the different types of dementia is a problem. And that's why expertise need to be, they need to see an expert to distinguish what type of dementia patient has. Because if you have a good diagnosis, patient will be able to get treatment. Without the correct diagnosis, treatment, you can't treat the patient, especially these days, since the new Alzheimer's drugs are approved only for the mild stage of the disease. If you have a patient who is in a mild stage of the disease, the earlier you send the patient to the memory specialist who knows, who's treating with specific types of treatment or new therapies, it's better. Because, I mean, if the patient is in a moderate stage, there are sometimes I can't help because the patient was with the primary care for such a long time that they are now in progress to a moderate stage. Those therapies won't help. So it's important to send the patient in an early stage.
I think we're in a catch-22 with some of the referrals because of the backlog of many of our memory centers across the country, not just here in Maryland. But I think we've noticed that that's certainly an issue for a lot of physicians to refer out to specialty clinics, such as the memory center or neurology groups that are doing memory work. But I guess we just have to keep plugging along.
Yeah.
Well, I think we're at our time, and I'd like to thank you so much. I think we will certainly put the names that Dr. Burhanullah mentioned in regards to the specialists that are available in regards to frontotemporal dementia that he mentioned. And then any other information and try to pass on to you as well. We're excited that we've had such a great informative presentation. Really makes us realize it's just more than Alzheimer's disease that we need to consider in our work with our older population with cognition. So thank you for your expertise and your time. We really do appreciate. We've all learned a lot from the comments in the chat. Our next session is June 19th, and Dr. Gallick, who is a professor at University of Maryland School of Nursing, is going to talk a little bit more about depression and delirium and understanding how that may present in a person with dementia. And we kind of hit upon a little of that today, but more detail in that regard. I'd like to thank everyone, again, our speaker, thank Wendy for organizing everything, and we're excited to continue this. It seems like there's been a lot of interest in our talk, so much appreciation.
I do want to share
Everyone have a great weekend.
the recording will be housed on the Living Well Center of Excellence website. Registration for the June 19th talk will be coming out shortly, and all the resources and previous PowerPoints, resource slides, etc., will be on our site as well. If you have any other questions, go to the second page of this PowerPoint and you can reach out to us for comment. Thank you again for attending today. Thank you, Doctor. We appreciate your informative talk, and have a great day. Enjoy your afternoon.
Thanks for having me.
Thanks again.